Wonderful. Thank you very much, Dr. Thane. It's a treat to be here on your 1 year birthday. Everyone can hear me okay and see the slides? Perfect. So today I thought I would talk a little bit about fracture management in chronic kidney disease. So we will go over, there we go, a little bit about epidemiology of fracture, discuss the evidence behind, kind of two broad categories of treatment, the stuff that we perseverate on in the dialysis unit, phosphates, PTHs, as well as some of the more kind of traditional osteoporosis therapy like anti-resorbatives and anabolics. And then we'll talk about some side effects and management thereof. So, kidney disease, as we all know, is a risk factor for fracture, and the degree of risk is really quite goes hand in hand with the degree of kidney dysfunction. So, those people on hemodialysis having a higher risk than those people with relatively mild kidney disease. And we see this across age groups. So, even though we typically envision the fractures as, in the geriatric realm, certainly in chronic kidney disease, we often see them at a younger age group. And the reason for this is multifactorial. Um, CKD mineral and bone disease, which we as nephrologists think a lot about, certainly plays a role in impacting bone pathology and strength. However, there are other things that also kind of co-occur. Often patients, even if they're not particularly advanced in age, do have functional changes related to their kidney disease. So they have a high risk of sarcopenia, high risk of frailty and falls that can predispose to fractures. Similarly, a lot of the comorbidities that we see along with chronic kidney disease, like diabetes, as well as some of the medications that we use to treat chronic kidney disease, like, for example, corticosteroids used in inflammatory kidney diseases, can contribute to fracture risk as well. And then lastly, we also know that chronic kidney disease and osteoporosis often coexist. Often they're in very similar patient populations, older patients. And women. And so as a result, we see some of the kind of general population changes as well. So what can we do about this risk? So first I'm going to chat about kind of the more nephrology specific things that we often tinker with in clinic and spend a lot of energy on, and the evidence behind that. So the first one is activated vitamin D. So many patients with advanced chronic kidney disease lose that ability to 1-alpha hydroxylate their vitamin D. And so as a result, we give them either calcidiol or calcitriol to help with hypocalcemia and hyperparathyroidism that come along with it. Does this help with their fracture risk? And the short answer is we don't know. There's some mixed evidence for bone density. Some studies show that it may increase bone density. Other studies show that it doesn't make a difference. There was one meta-analysis with a whopping 27 fractures in the whole meta-analysis that didn't really show an effect one way or another. Although the difficulty with studying with fractures is just the relative rarity of the event and small sample sizes. So a bit unclear whether or not the calcitriol that we add assiduously to titrate the PTH does anything for us. The next thing is impacting parathyroid hormone specifically. So one of the tools we have in our toolbox is calcimimetic, so cinacalcet. And I like showing this because this is one of the very few examples where we actually have more evidence in the advanced chronic kidney disease realm than we do in the general population. So there was a trial called the Evolve trial, which looked at the effect of cinacalcet on cardiovascular events and mortality, and it included everyone with a PTH above 30 in our units picomoles per liter, which would be about 5 times the upper limit of normal. So not that high from a nephrology dialysis perspective, but high from a general population perspective. And so they included everyone with a PTH that was moderately elevated and looked at outcomes. So there was this pre-specified subgroup a sub-study looking specifically at fracture outcomes. And it did show that in those who were over 65, there was actually a fracture benefit in those given cinacalcet in the setting of secondary or tertiary hyperparathyroidism. Similarly, when we look at parathyroidectomy, there's not any good randomized controlled trials. All of this is observational, and obviously there's lots of confounding about who is fit enough to receive parathyroidectomy surgery. But there is some potential benefit to taking out parathyroids in patients with advanced enough secondary hyperparathyroidism. The question of what is advanced enough and when to do that is still a little bit of an open question, though. The next thing is vitamin D3 or nutritional vitamin D. So we know that deficiency is very common. We also know that there's a pretty robust association between low vitamin D levels and increased risk of fracture, cardiovascular mortality. We don't know right now whether intervening on that will actually change anything. So there is a trial going on right now called the Simplify trial in the UK, which is looking at giving patients on dialysis vitamin D3 intravenously every 2 weeks. And they'll be looking specifically at hospitalizations, cardiovascular mortality, and fractures. We do know that in patients with secondary hyperparathyroidism, supplementing them with regular old basic nutritional vitamin D will help improve the parathyroid level. It's not as potent as an activated vitamin D, but it is always a good first step, particularly in those with, relatively mild chronic kidney disease. We also do know, because sometimes this is a point of concern, that nutritional vitamin D supplementation will not significantly increase your urinary calcium. So in somebody who has a history of calcium-based stones or nephrocalcinosis, nutritional vitamin D supplementation won't actually make any of that worse, which is somewhat reassuring. So now I'll spend some time talking about kind of more traditional osteoporosis treatments. And I think it's important first to just chat a little bit about bone turnover setting of chronic kidney disease and how we approach this. So there are a number of different pathologies that you can see in bone in patients with chronic kidney disease. Generally, we kind of lump these into two buckets: low bone turnover, so that would be adynamic bone disease and osteomalacia, and high bone turnover, which would be osteitis fibrosa or mild disease. And we know that even in patients with stage 3 to 5 chronic kidney disease, so GFRs, in the 30s, 40s, we do know that there is a relatively high proportion of people who have adynamic bone disease or osteomalacia. As you can see here, we're dealing with about 24% or 26% rather, as well as those that have high bone turnover disease. In peritoneal dialysis, certainly we see a little bit more low bone turnover disease. I don't have a good reason for that, nor does anyone have a great reason for why that's the case. And of course, it becomes important to distinguish what type of bone disease the patient has before we think about, anti-resorptive therapies that may modulate bone turnover. So how do we do this? So in the olden days, we used to do bone biopsy, which has become essentially practically impossible to get, at least in Ontario. I know in Ontario, there are no pathologists that will actually read a bone biopsy. They have to get sent to Quebec. It's a bit of an endeavor. So as a result, we've kind of moved on to using parathyroid hormone and bone-specific alkaline phosphatase. One thing that is important to look at in studies that have looked at these bone turnover surrogates is that it's a lot easier to rule out low or high turnover than it is to rule it in, which is actually not bad in our circumstance, because fundamentally what we want to use these markers for before we think about anti-resorptive therapy is we want to rule out low bone turnover disease. And so typically my approach has been, and this, has some reasonable evidence behind it, to avoid anti-resorptive therapies when the PTH is below our target. And typically in dialysis, that would be a target of 2 times the upper limit of normal or higher. So if it's below 2 times the upper limit of normal, or if the bone-specific alkaline phosphatase is low, in a patient receiving dialysis, I would avoid an anti-resorptive therapy for that. The question is a little bit trickier when you look at pre-dialysis chronic kidney disease, because we don't have as much evidence in that regard. However, in somebody, and the degree of elevation of PTH that you would expect to see really varies depending on the degree of advanced chronic of kidney disease that the patient has. However, in a patient with relatively advanced chronic kidney disease, GFR is less than 20, I would expect some elevation of the PTH. So if the PTH was normal in that case, it might give you pause to potentially start bisphosphonates. Now, I will also say that the concern about low bone turnover is largely theoretical. There haven't been any studies that have shown that anti-resorptives potentiating low bone turnover disease actually worsen fracture outcomes in this patient population, but it's certainly a theoretical risk we think about. So looking at the evidence behind bisphosphonates specifically, we know that they're well proven in the general population. The figure on the left is from the fracture intervention trial. And we know that the evidence, the randomized controlled trial evidence in patients with chronic kidney disease is poor. So the figure on the right is a post hoc analysis of the fracture intervention trial, where basically, because they use a creatinine cutoff rather than a creatinine clearance cutoff, there were a modest number of people with moderate chronic kidney disease that were included. As you can see, some with a GFR less than 45, really very, very few people with a GFR less than 30. So this is kind of in your stage 3 chronic kidney disease that this is applicable to. And there was no evidence that this efficacy or the side effect profile changed compared to the general population. I will note that in all of the efficacy trials of antiresorbatives, those with evidence of CKD-MBD were excluded. So patients with high PTHs at baseline were not included. When we look specifically at bisphosphonates in dialysis, the evidence is obviously even sparser. There's one randomized control trial that was done in this regard. So basically, this was looking at both bisphosphonates and denosumab. We'll talk more about that later, and followed bone mineral density over a year. And they did find that bisphosphonates, as well as denosumab, increased the bone density at lumbar spine, but didn't have an effect at the femoral neck and the distal radius. Importantly, from a safety perspective, there were no changes in markers of coronary artery calcification, which is one of the concerns with giving bisphosphonates. There are no other RCTs in this area, but this is kind of the limited evidence we're stuck with. In patients with non-dialysis requiring chronic kidney disease, there's a little bit more evidence. So there was recently a meta-analysis published done by a Canadian nephrologist that looked at RCTs that included over 7,000 patients. Now, none of them had stage 5 chronic kidney disease. None of them were on dialysis. So this was a relatively healthier population than some. They were shown to be protective against fracture for every stage except stage 3B, which would be a GFR from 30 to 45. I think this is most likely kind of an artifact of multiple comparisons, as opposed to, for some reason, it works if your GFR is above 45 or below 30, but not in between. And they also increased bone mineral density across the spectrum of chronic kidney disease. And importantly, there was no interaction between CKD stage and efficacy. So the degree of your chronic kidney disease didn't actually moderate how beneficial it was. Now, one of the things that always kind of is in the back of everyone's mind when they're giving bisphosphonates is, how is this going to affect GFR? So IV bisphosphonates, when they were started being given for hypercalcemia, malignancy, and to reduce skeletal-related events in the oncology realm, kind of got a bit of a bad rap. There are associations and case reports of both abadronate and zoledronic acid being associated with collapsing focal segmental glomerulosclerosis. In those who were given oral bisphosphonates, the evidence is a little bit mixed. So there was a study that in Ontario that was observational, and it looked at everyone given bisphosphonates and whether or not there was a change in GFR, which was negative, and showed that there wasn't a significant impact on GFR. However, another cohort that was done in UK and Spain that importantly did limit it to patients with a GFR of less than 45 to begin with, so perhaps a higher risk patient population than all comers, did show 15% risk of worsening CKD stage. Now, not many of those, ended up being dialysis transplant. Most of them, it was a change from stage 3 to stage 4, that sort of thing. So a little bit kind of up in the air as to the effect. However, we certainly know in higher GFRs, they can be relatively safe. So what's the bottom line? Kind of what's my approach in using bisphosphonates in advanced CKD? I think that because of the way the efficacy trials were done, with including patients that had a slightly lower GFRs than perhaps or creatinine clearances than perhaps were intended. I think it's likely safe with an eGFR or creatinine clearance above 25. So, if I have that person in clinic whose creatinine clearance or GFR is hovering around the 30 range, I will not get excited about stopping bisphosphonate anytime soon. I think the biggest risks are the worsening of adenogenic bone disease, and with that, some vascular calcification. Once again, highly theoretical, as well as worsening of renal disease. They are renally cleared, so there is some precedent for giving half-dose bisphosphonates, particularly in patients that are not on dialysis. They are cleared by dialysis as well, too. So if somebody has advanced chronic kidney disease, you'd like to give it, but they're not on dialysis yet, I would certainly think about, a half dose rather than a full dose. There is a trial going on right now in Australia using full dose risedronate in patients on dialysis. So it'll be interesting to see the bone mineral density outcomes after that. And then the other thing that always kind of comes up in my practice is the older patient who's been on bisphosphonates forever and their renal function has slowly deteriorated over time. And usually my approach in that one, assuming they haven't had any fracture events, would be to recheck their bone mineral density, and if they're due for a drug holiday, considering that before doing anything else. So next, talk a little bit about denosumab. This is obviously somewhat promising because it's not renally cleared, unlike bisphosphonates. We know that they're effective in the general population. I always put this slide up, particularly for my nephrology colleagues as well, too, because to show that they're also relatively effective on a short time frame. A patient doesn't need to have a life expectancy of 5 years in order to accrue the benefits of denosumab or bisphosphonates for that matter. In advanced chronic kidney disease, the level of evidence is very similar to that in denosumab. So there were some post-hoc analyses of the main landmark efficacy trials of denosumab, which basically showed that in those with moderate chronic kidney disease, GFRs above 30, stage 2, 3 chronic kidney disease, there was really no change in efficacy, no change in side effect profile. In the advanced chronic kidney disease population, there was some slight increase in, so the light gray bars is the advanced chronic kidney disease, no hemodialysis. There was an improvement in bone mineral density at both the lumbar spine and the femoral neck in patients who were given that for over a year. In dialysis, the results are relatively similar. We have pretty good evidence, and this is a meta-analysis, that it will increase bone mineral density both at the femoral neck and lumbar spine. It's approximately a 9% increase in at both locations based on this meta-analysis. However, I think the important thing that this also came up with was that there was a significant risk of transient hypocalcemia, and we'll talk a little bit more about that later. And the other thing we notice, and it's not surprising, is that when we look at parathyroid hormone and ALP in this population, we do see a sustained decrease in that. Unlike the hypocalcemia, which resolved itself after 4 to 6 weeks, the PTH and the ALP were suppressed kind of chronically, in keeping with decreasing bone turnover. So what is the risk of hypocalcemia with denosumab? And Tharsan, I'll try not to step on your toes too much with this. But we do know that it is significant. And it is perhaps higher than, the product monographs or original studies of this indicate. So this was a study that we did in Ontario, looking at almost 60,000 patients who were on denosumab. 174 of those had a GFR less than 15, so numbers dropped off significantly. There were a couple of interesting things about this. So only about a third of patients had a calcium done prior to starting denosumab, and only about a third of patients had a calcium done after starting denosumab. And we looked at the calcium in the next 6 months. So this was not, ideally timed to identify hypocalcemia. The other interesting thing is the vast majority of these prescriptions were given by general practitioners, even in those patients with really advanced chronic kidney disease. And I think this is sort of reflective of a lot of the guidelines that don't really discuss much about renal disease, and certainly don't give guidance around calcium testing in the setting of hypocalcemia. We know that the time frame is about 2 to 4 weeks after the injection. And the risk factors are, what you might expect. So a lower baseline calcium, a lower baseline EGFR. Patients who have a lower vitamin D, which also serum vitamin D, which also makes sense and was also not checked very commonly in advanced chronic kidney disease, and those who have an elevated PTH to begin with. This just shows a similar trial published in JAMA about a year later that shows that really we're seeing that peak in the kind of 4-week range. Although even up to 10 weeks out, patients have a higher risk of hypocalcemia with denosumab than bisphosphonates. Preventing hypocalcemia, I will go over super briefly because Tharsa and I suspect you are talking about much of this. Only to say it is possible. However, it does take a lot of work, both on the part of the provider and the patient. And, at St. Joe's, we're lucky because we have a pretty streamlined system to do all of this. Similarly, in the dialysis unit, we can check blood work 3 times a week if we want to, but, it is doable, but not without significant effort. Similarly, in the dialysis unit, we have a protocol that relies primarily on changing the dialysate calcium and giving IV calcitriol. The main reason for that being it's just less burden on the patients. You're not telling them, take 10 tums, wait, no, take 8 tums. Okay, don't take them with meals, take them with meals. There's a lot of varying that can happen with this stuff, and trying to do as much of it on the dialysis unit as possible is helpful. I would be remiss without just briefly touching on cardiovascular risk of denosumab, only because this paper, when it came out in 2025, kind of caused everyone to take a step back. So this was a target trial emulation study that was retrospective out of Japan and observational, and it did show a 45% relative decrease in fractures, which is wonderful, but a 36% relative increase in cardiovascular events. It's hard to know what exactly is going on here, whether this is driven by confounding. We know that fracture risk and cardiovascular events also go hand in hand. So, perhaps those individuals with the higher fracture risk were getting denosumab rather than bisphosphonates. We do know that there are some basic science studies that show that there isn't any significant increase in vascular calcification with denosumab. But certainly this, bears a little bit more research over the next number of years. Very quick word on denosumab discontinuation, only that, as you all know, and this is more, I have to tell my nephrology colleagues this all the time, we can't just stop it. There's a significant decrease in bone mineral density afterwards. So in that patient who has been on denosumab for years and years and their GFR has slowly declined over time, it behooves us to think about, should we switch them to a bisphosphonate? Should we do denosumab with closer monitoring, rather than, the first time they have hypocalcemia saying, oh, this drug isn't for you, and stopping and putting them at higher risk. Very quickly, I will talk about teriparatide, only because it's a question that comes up a lot. So it's a PTH analog. And there are some patients, as we talked about, particularly peritoneal dialysis patients, who actually have lower bone turnover than we would like. And perhaps teriparatide could be used as an anabolic agent. It is renally cleared. There have been some small case series, 7 to 22 patients looking at the effect on bone mineral density in dialysis. Most often it's given once weekly because of the renal clearance. And it's all in patients with below target parathyroid hormones, obviously. There is some improvement in bone mineral density at the lumbar spine. But there was also some transient hypotension. So no clear answers on whether teriparatide is going to be our magic bullet for those people with, undetectable PTHs or PTHs of 5 or 6 in dialysis. But I put it in there only because we always get questions about this. So just sort of to summarize, this is my approach to fracture assessment and potential treatment in patients receiving dialysis. So who do I think about even looking at fracture? And so certainly if they've had a previous fracture, these are the low-hanging fruit. And I still think that, from a nephrology perspective, we're not doing a good enough job of this. So, if nothing else, looking at our patients with previous fracture, but then looking at other people with risk factors like higher age, lower weight, people who have been on multiple courses of steroids before, or those who have significant hyperparathyroidism. Right now, we're using FRAX for fracture risk assessment. If they've got a high risk or multiple previous fragility fractures, start with lifestyle measurements, and then I look specifically at bone turnover. And if bone turnover is looking like it's low, PTH is below two times the upper limit of normal, bone-specific ALP is low, then unfortunately we're stuck here and there's not a lot to do. Um, if their bone turnover is looking pretty reasonable, either it's normal for dialysis or on the higher end, then the next step is looking if they have too high of bone turnover. So if they have hyperparathyroidism warranting treatment, PTH greater than 9 times the upper limit of normal, PTH a little bit less than that, but in the setting of hypercalcemia, previous fracture, then I will first target the hyperparathyroidism. That's either parathyroidectomy or cinecalcet, primarily driven by what we can get coverage for. And if they're not, then I look at, what's their life expectancy? How keen are they on addressing this? Do they have the mobility, to come to and from for labs and things? And if the answer is yes, then we talk about referral to a multidisciplinary team to discuss benefits of either antiresorptives or anabolic medications. So with that, I will open it up for questions. And we have 15 minutes for questions, Dr. Thane?
Yeah, we have 15 minutes for questions if anybody has them. And thank you, Andrea, for such a wonderful overview of a really complex topic. I always have lots of questions for you. And I know Cavi, one of my residents, is on today, and we seem to have, CKD and BD fracture day yesterday in clinic. So I'm just going to open it up to the audience to see if there are any questions before I get in there. Shara's just asking, could you go back to the last slide before the questions one?
Absolutely.
I think while people are thinking of their questions, I'll start off then, Andrea. And I'm just asking, I can see that there's a bunch of geriatricians on here, and I'm going to ask you this question because I ask it to you all the time. When you're doing these assessments, do you tend to use creatinine clearance or EGFR? Because particularly with the elderly female frail at a lady in clinic yesterday who weighed 29 kilos, I always get a little bit anxious using the EGFR, but I know that that's the one that's often commonly quoted. So what do you do in your practice?
That's a great question. And so, I think some of this is a philosophical debate. Um, in we know that in the on a population basis, EGFR does a better job of kind of capturing chronic kidney disease state than creatinine clearance. However, that having been said, most of the drug studies were done using creatinine clearance, and particularly, the geriatrics population is not the whole population, right? So as you said, there's a lot more frailty, there's a lot more low BMI. Women are notoriously you take any woman over 70, their creatinine clearance is going to be low. So what I tend to do is I will be honest, as a nephrologist, because I deal with EGFR a lot, that's usually my first port of call. However, if I'm looking specifically at drug dosing and I'm looking specifically at somebody who may be on the extreme, so either lower BMI or higher BMI, or body surface area, then I will go to creatinine clearance. Only because, and often I'll measure both of them and then kind of decide. The other thing that I will sometimes do, and we can do in London, is measure a cystatin C, particularly in somebody with low muscle mass, because I think often their cystatin CGFR is a lot lower than their EGFR or creatinine clearance because they're just so sarcopenic. So I think that's another good option. And sometimes I'll do all three and then kind of gestalt it and go, well, I think probably most likely it's heading in this realm.
Do you mind just expanding a little bit more about cystatin C?
Yeah, so creatinine clearance, so creatinine, because it's a byproduct of muscle breakdown, it's driven by, so creatinine is based on muscle as well as renal function. And so when we do either creatinine clearance or EGFR, there is some inherent assumption about the patient's muscle mass. Cystatin C is not based on muscle at all. It's not available in all centers because Guido Filler, who works here, did a lot of research on it. You can order it on PowerChart. and it will give you a muscle mass free kind of estimation of GFR, not creatinine clearance, obviously. But it'll give you an estimation of GFR. On our EMR, what it'll do is it'll give you it'll use an equation that actually uses both creatinine and cystatin C, but I usually also calculate it with just cystatin C. So if somebody is at an extreme of muscle, so for example, the 29-kilo lady, cystatin C would probably be a good idea. Similarly, the 120-kilo bodybuilder is, that's somebody that I also use it in, but that can be a good option in somebody who is sarcopenic to get around some of the questions of, even creatinine clearance, how good is it at estimating, you give the weight, but what's the muscle versus fat component.
Great, thank you. Nadine, you have a question?
Thank you so much, Andrea, for this great presentation. I do have a question. You mentioned that we are giving half the dose of bisphosphonate if we have a patient who's pre-hemodialysis. Can you elaborate more on that? Would that be with oral bisphosphonates, since we don't give IV Zol for a patient with that kind of eGFR? And what cutoff would be?
Yeah, that's a good question. So yeah, so I mean, the people practically that I have done this with are patients, for example, who have been on denosumab, run into issues with hypocalcemia. I say, I'm not going to the lab twice a week to get my calcium checked, but we need to put them on something from an anti-resorptive perspective. We can use half-dose bisphosphonate. I would say typically if I'm reaching for an anti-resorptive in the pre-dialysis population, I'm probably going to favor denosumab over bisphosphonate. Although if you talk to, other experts at different centers, they would say the exact opposite. It's highly opinion based, obviously. In dialysis, I have seen and done both, either full dose or half dose. There is a theoretical risk because it's renally cleared of, more accumulation. May it worsen, risk of bisphosphonate related to osteonecrosis of the jaw or atypical femoral fracture. It's hard to know. So sometimes a half dose is kind of a nice kind of in between option. But I will say, if somebody is anti-resorptive naive, I would usually start with denosumab before bisphosphonates, and that's partly because of all of the work Tharsan is going to produce or going to present soon.
Thanks. Shara's put a question. I think part of this is going to go into what Tharsan's talking about, but she has some specific questions about calcium supplementation. What's your advice regarding calcium supplementation dietary advice in this population, specifically for bone health? And do you favor calcium-based phosphate binders?
That's a good question. So the very practical answer is, in Ontario at least, our access to non-calcium based binders is quite poor. So basically, Tums is everyone's first line. So patients are often getting a decent amount of calcium through that. The other thing that kind of complicates things is a lot of the dietary sources of calcium are limited because we're also limiting patients' phosphate and potassium. So, their dark leafy greens they can't have because of the potassium, the dairy they can't have because of the phosphate. So, I think and patients' appetites are often poor, they have a little bit of uremia. So, the amount of dietary calcium that patients are taking in is generally quite poor. I will leave the discussion of calcium supplementation around denosumab to Tharsan because that's an area in and of itself. Typically, my advice, and there's no good evidence on this, but my advice in the dialysis population would be, if I'm worried about bone health, but I'm not worried about vascular calcification, and that's kind of the big asterisk with this, obviously, is I would see if we can increase dietary calcium, and if that's not working, I would favor a calcium-based phosphate binder. I have not routinely given people calcium who don't have either hypocalcemia or hyperphosphatemia that warrant replacement, just because I think the risk of vascular calcification is so high. And we're often a little bit permissive to like serum calcium, as long as it's above 1.9 in the dialysis population. For me, I typically will not supplement it, only because I do worry about the risk of vascular calcification. It's just so much more rapid, valves, arteries, so much more rapid than in the general population, that I won't give calcium additionally.
If we have a couple more minutes, can I ask you another question that I know I've debated with Kristen a couple of times as well? Given that this is, and I know that this is a hip fracture group, but we do see some patients for primary prevention as well. And sometimes, particularly when you're giving medications like denosumab that require a lot of intensive, management on everybody's side, what is your general gestalt and feeling around starting people who, their frac score is a little bit high, but they've never had a fracture, and this is entirely for primary prevention, they're quite young, as opposed to people who have, in this population had a hip fracture already and they've kind of gone through that. Obviously, we want to prevent that from happening, but at the same time, it's a lot.
Yes. Yeah. That's a great question. And if I had to answer that, I would be a happy woman. So you're absolutely correct. And on this slide, it kind of alludes to that. If they've had a previous fragility fracture, I think it's really easy to say, listen, we don't want this to happen again. Here, you remember that hospital stay, this is bad. And I think it's a little bit easier to get both clinician buy-in as well as patient buy-in. In the primary prevention realm, as you said, it's super important because we know that the mortality after hip fracture in a patient receiving dialysis is 50% at 1 year. So many of them will not live to that second fracture that we will so valiantly prevent. I think it depends a lot on the patient, and I do kind of have a lot of discussions with patients and let them think about it as well. I think that especially in the pre-dialysis or the home dialysis population, where they are going to be schlepping to and from the lab 3 times a week. There are some patients for whom they have a lot of, they're happy to do that. And they say, you know what, this is really important to me. There are other patients who say, not in a month of Sundays. And I certainly won't push it, because I think, doing it without good patient buy-in just results in complications that you don't necessarily want. The risk of hypocalcemia should be lower after kind of second, third doses as the bone turnover is suppressed. So that's, somewhat reassuring if they can get through the first one. I think that, there are people, and the final point, I think that there are people who would benefit from this, but I'm not sure we have a great way of capturing them and predicting who that would be. If I could say with 100% certainty, yes, you'll have a fracture within the next 5 years, of course, it would be a no-brainer. But I don't think our predictive ability is there yet. Frax has not been super well tested in the advanced CKD population, and certainly in dialysis. So I think that is kind of one of the limitations, is that without a good predictive option, it is hard to have these discussions. Yeah. I wish I had the perfect answer for you.
Thanks. Maybe we'll get there one day. And I'll let Angela have the last question. So she says, thank you for the presentation. Can you please comment on the role of vitamin K2 in these patients?
That's a great question. So the primary use, as a nephrologist, the primary time that we would use vitamin K2 in these patients is somebody with significant calciphylaxis. So calcific uremic arteriolar disease. So often you get calcification in small blood vessels, results in terrible ulcers, necrosis, has a very high mortality rate, 50% of the year again. So that's the primary time that we will use vitamin K2 in terms of a decreasing vascular calcification sort of risk. I have not seen clinically or am aware of anything in the kind of fracture prevention realm, but there is sort of some weak evidence in the, decreasing vascular calcification realm. I don't know if anyone else has any good experience with it, but yeah, we haven't used it a lot in the fracture realm, but I can't point you to a paper that says it works or doesn't work.
Great. Thank you so much, Andrea, for sharing all of your pearls of wisdom and coming to speak with us today.